Okay, so welcome everybody to the WHS Journal Club for July. We have a presentation by Dr. Thant Lwin. And actually, this is a really interesting topic. I mean, they're all interesting topics. Of course, they're all interesting topics. But actually, this is something that is very interesting and I think very relevant to our kind of everyday practice, but something that we maybe don't think about as much as we should do. So I'll hand over to the presentation. We'll allow you to take us through it. I'll try not to interrupt you unless there's anything really pressing, and then we'll have a bit of a discussion at the end about the paper, its strengths, possible weaknesses, and what we think about the message that it's conveying. So over to you.
Okay, thank you, Mark. I'm Dr. Zeyar. I'm from Yangon, Myanmar. I'm a GP. Okay. Good afternoon, everyone. Today, I'll be presenting a recent paper published in Cephalalgia in 2026. The title is Physical Activity in Migraine, Identifying an Engagement Threshold and Patient Cluster in a Population-Based Cohort. Okay. And this paper examines three important questions. And does regular exercise improve our migraine outcomes? Is there a migraine severity threshold that prevents patients from exercising? So this is the title and authors. Okay. And, migraine management has improved with anti-CGRP therapies in Japan, but these medications remain expensive and not everyone responds adequately. And in addition, depression and anxiety frequently coexist with migraine and significantly affect patients' quality of life. So lifestyle interventions remain important. So physical activity. Studies have shown that regular aerobic exercise can reduce migraine frequency by approximately 30 to 50%. Interestingly, this benefit is comparable to some preventive medications, while avoiding medication-related adverse effects. Exercise also improves mood and overall well-being. Yeah, however, there is an important paradox. Exercise helps reduce migraine, but patients with severe migraine often cannot exercise because of frequent headaches, fatigue, and depression prevent them from being physically active. This creates a vicious cycle, which this study aimed to understand. So the authors have three objectives. First, to determine whether at least 2 hours of exercise per week is associated with better migraine and mental health outcomes. Second, to identify a migraine frequency threshold beyond which patients stop exercising. Third, to identify patient cluster with similar characteristics. And this was a population-based cross-sectional study from southern Israel involving 550 adults with migraine. Participants were randomly selected from a large migraine registry, and migraine diagnoses were confirmed through questionnaires. Because this is cross-sectional, it can only demonstrate association, not causation. So physical activity was simply defined as exercising more than 2 hours per week. Migraine disability was assessed using MIDAS. Depression, anxiety, and stress were measured using DAS-21. Burnout was assessed using MBIGS, and overall life satisfaction was also evaluated. The authors adjusted for important demographic factors using multivariable regression, and logistic regression was used to estimate the probability of exercising. Finally, K-means clustering identified different patient profiles. Here, almost half the participants were physically active. Compared with inactive patients, active patients experienced fewer migraine days, lower triptan use, lower disability scores, less presenteeism at work, and better life satisfaction. Overall, physically active patients consistently had better clinical outcomes. After adjusting for confounding variables, physical activity remained independently associated with lower migraine disability and better quality of life. One particularly interesting finding was the 3-day threshold. Patients experiencing approximately 3 migraine days per month had only a 50% chance of being physically active. Beyond this point, the likelihood of exercising declined substantially. This finding forms the basis of the author's proposed treatment strategy. Okay, patient cluster. Using the cluster analysis, patients naturally fell into 3 groups. First, the trapped group had severe migraine, high depression, no exercise, poor quality of life. Second, the functioning but sedentary group had moderate migraine burden, but still exercised very little. Finally, the active and functional group had the lowest disability and least depressing and the best quality of life. So the authors concluded that even modest physical activity provides clinically meaningful benefits. Interestingly, once demographic factors were considered, exercise was no longer independently associated with depression, suggesting that disease burden itself may explain much of psychological impact. Okay, this is pharmacology-enabled physical activity. Pharmacotherapy shouldn't replace exercise. It should be used to lower the headache burden, so the patient are physically capable of exercising. Okay. The strengths include a large population-based sample, addressing a clinically relevant question, and introducing a practical threshold that clinicians can easily remember. And limitation, the major limitation is the cross-sectional design, so causality cannot be established. Physical activity was measured only as yes or no without considering intensity or type of exercise. Finally, all measurements were self-reported, introducing potential recall and reporting bias. To summarize, just 2 hours of exercise per week is associated with fewer migraine days, reduced disability, less medication use, and improved quality of life. However, patients with more than 3 migraine days per month are much less likely to exercise. Therefore, reducing headache frequency may be the first step toward enabling patients to adopt a healthier lifestyle. So this study shifts our approach from simply telling patients to exercise towards first making exercise achievable. In other words, effective pharmacological treatment can enable patients to become physically active, creating more sustainable management strategy. So these are the points for discussion. So how can we better incorporate lifestyle counseling into busy, or GP clinic? So that's the first one. And the second thing is how could you consider regular exercise as a marker of successful migraine control when deciding whether to reduce preventive therapy? That's my point for discussion. Okay. Thank you for your attention.
Yeah, thank you, Dr. Zeyar. That's a very good summary of that paper.
Thank
Do
you.
you want me to just go back to the previous slide and just leave those points for discussion up on the screen? We've obviously got a few people in attendance here, and I just wondered whether anybody who's listening in would routinely uh, ask their migraine patients about exercise. Is there anybody that would routinely do that as part of your history taking? So none of us routinely ask patients about exercise. Okay. Um, is is there anybody that, having just heard that presentation, now thinks that they would ask patients about exercise? Anybody like to put a thumbs up on the screen, on their screen, or anything like that, if they think that what they've just seen might change their practice? Yeah. Yeah. Okay. Yeah. Okay. So a few people. Interesting. All right. So, uh, Dr. Zeyar, what? Because I think one of I mean, firstly, I mean, just in terms of, let's just discuss the sort of quality of the paper. Do you think, firstly, in terms of the way that the paper was done, what are your thoughts on that? Firstly, patient population. Do we think this is an appropriate patient population to do this sort of study on? Yeah. Okay. So here we go. The population. Yeah. Go back a couple of slides. Where was it? Keep going. There we go. So do we think this is an appropriate population for this type of study?
Yeah, in Israel now, the study, I think it's very difficult for them to um, do such study. So I'm not very sure about it.
I mean, what would you need to, uh, what would you need, what ideally would you want for a study like this? So it's a population-based study. Okay. So um, this is, I have to say I wasn't familiar with the Negev migraine cohort, but having had a quick look, I understand that it's a population-based study that actually has, tens of thousands of people in a longitudinal
Awesome.
study. So this is a relatively sort of small population of this, or a small portion of the people within the general cohort. Um, and they're using some form of randomized sampling. They've got about a 50% response rate to the people that they've approached. Now, okay, so could that introduce a bias? We don't know how they approach people. Did they approach people say we want to do a study on physical activity? Are the people that kind of decide not to take part of people, maybe would they be more likely to be, less engaged in physical activity and therefore less likely to want to necessarily take part in a study? And maybe people that are more engaged in physical activity would be more likely to say yes because they feel, good about themselves because they're they're doing this. Is to do, could there be a bias in from that?
Yeah, good point.
Yeah. The answer is yes, it's possible.
Yes,
We don't know, we don't know, we don't know enough about the necessarily about the nature
population. Yeah,
of the cohort and the population.
yes.
But it seems to be a large scale epidemiological study. That they're random. They're purportedly at least doing random sampling, so it would seem to be a sensible number. And is 550 a sufficient? Does that make a sufficiently powered study? Well, the statistical analysis, as far as we can see, does appear to be kind of sound. Um, I don't know whether anybody in this meeting knows very much about k-means clustering as a technique. I don't know whether anybody's familiar with this statistical technique.
For me, I'm not familiar with that.
I think my understanding is that it's a kind of machine learning algorithm that basically you put the information into a kind of n-dimensional kind of space, and then the machine starts to put kind of center points within that data space, and then kind of looks at how far all the individual points are away, and it kind of just works its way through and tries to establish a sort of pattern of clustering, and and then comes up with however many clusters it seems to that seem to kind of fit the pattern. Again, just in terms of kind of the common sense kind of view of this, they come up at the end with kind of three sort of sets of clusters, and again, that's quite an interesting one. Maybe you just want to, if you just go to the slide which has the patient clusters in them.
Okay.
Do we reckon? Do people think they recognise these types of patients? Do you think would? Does this look like, just with a common sense approach to, this as a result, saying, okay, look, there are basically three types of people here. There are people that have got a very high migraine burden, and their migraines are so active that it actually makes them very difficult to exercise. These are the trapped group. And then on the other end of the spectrum, you've got the people who have far fewer migraines and are all quite active, and kind of, and have, the lowest level of anxiety and depression and everything. So these are people that are doing quite well. And then in the middle, you've got this functioning, what they've called functioning but sedentary, that they're kind of in the middle. And there's quite a large, it's about 40% of those people, isn't it? What would
Yeah,
you do? What would you do with those people?
maybe we ask for their physical activity, about the physical activity, and yeah,
So I think it's an interesting question, isn't it? Because they talk in this paper about, okay, they talk about physical activity as a secondary intervention. So they
all
say,
right.
okay, look, we've got this set of people that are very physically active and they do very well. They're doing very well. And their conclusion is what we need to do is we need to, treat people pharmaceutically to improve them to a point where they can start to engage in physical
Physical
exercise.
activity. Yeah,
But we know from this and other studies that physical exercise itself is associated with better outcomes in migraine. We know from studies, for example, of where longitudinal studies which look at the risk factors for transformation from episodic to chronic migraine, that physical exercise is potentially protective against that, and lack of exercise and obesity makes that transformation more likely to happen. So is there a role here, do we think, for encouraging physical exercise as a primary intervention in perhaps people in that middle group where they are still functioning, they're relatively sedentary, but they've got low rates of physical activity, but they are maybe not in a situation where they are so bad that they cannot exercise?
Maybe they might need some medications.
Yeah, I mean, I think that's the question. I mean, I look at this data and I go, okay, well, that's really interesting. So we've got a really bad, we've got the trap group, the people that are really bad, and we all see patients that, that can't exercise because it makes their migraines worse, and they're quite difficult actually to manage. People with exercise-induced migraine, it's quite a difficult trigger to manage. So there is that group, and for those people, there's no, you're going to have to find some way of kind of calming down those migraine networks and improving matters. And then on the other end of the spectrum, you've got people who are doing really well and they're very active, and and that's great. But in this middle group, this functioning but sedentary group, yes, they may need pharmaceutical intervention. But I think the part of my takeaway from this paper was that actually there is this group in the middle in which they probably could exercise more. They probably should exercise more. They probably can exercise more, and probably as part of the lifestyle advice that we give people in terms of caffeine and hydration and sleep and all the rest of it, maybe we should be being more specific about exercise and more specific, and then actually being, and then again, and then the secondary question from that is, well, this study suggests that there's a threshold at around about 2 hours a week. Should we be specifically saying to people, look, actually, if you can exercise at some form of intensity for more than 2 hours a week, then we know that that is accompanied by improved migraine outcomes.
Yes.
Yeah. Yeah. Okay. Just go back a couple of just one or two slides. Just go back. So, okay. So, with Midas, because obviously, look, there are, when we look at grading scales for the impact of migraine, there are kind of there are two standard scales that have been used over the last 20 to 30 years. So obviously one of them is Midas, the Migraine Impact Disability Assessment Score, and the other one is HIT6, it's a headache impact test, which you'll all be familiar with. With Midas, what would you, I guess, regard as, a kind of clinically meaningful change, a clinically meaningful difference? Because it's important, isn't it? When you read papers and you read, a paper says, okay, well, the monthly migraine days did this, and you go, okay, but what about quality of life? What was the impact on quality of life? And you look for a HIT6 score or a Midas score. What's what people have this kind of idea that there is a kind of a minimal meaningful improvement. So what would you say that you'd expect that to be?
About the Midas score,
Yeah.
improvement in that score questionnaire.
Yeah, but how much is 1 point? If your Midas goes down from 26 to 25,
Yes.
is that a clinically meaningful improvement?
I think the questions are a lot sometimes complicated for get an answer like that.
Yeah, no, that's true. But I think that there would generally be there's generally be a, um, normally you'd kind of be looking for, some type of, some general level of improvement, on these scales that you could look at and go, well, that's a meaningful improvement. So, if your MIDA score changes by 1, is that a meaningful improvement? It's not really, is it? Because, from day to day, the score, those individual scores, parts of the component, there might be just one up, one down. So that's generally not thought to be a meaningful improvement. Okay. So I think this is really important, and it's good to have a sense of these things. So with MIDAS, again, the level of meaningful improvement is a little bit dependent on where you start. Um, but in general, most studies suggest that a drop by 4.5 or more points on MIDAS is probably, equivalent to what patients would say, yeah, that's a noticeable and meaningful improvement. At the lower levels, you want perhaps a drop of up to 30%, but as a sort of very minimal thing, anything that doesn't shift the bar on MIDAS by more than about 4.5% is probably not a meaningful improvement. And it's a similar kind of number for hit six. Generally with hit six, the hit six scores, go up to 78 is the maximum, and again a decrease of around about 6 points, 5 or 6 points is generally thought to be meaningful. So if you look, for example, at the CGRP papers, most of the CGRP monoclonals, and you look at the decrease in hit six on those, you're mostly seeing levels of about 6 or 7 over the course of that, over the 3-month trial period. So, I mean, firstly, the active versus inactive groups, there's a difference of 10 points on the MIDAS score, on the average MIDAS score. So that is, pretty clearly a clinically meaningful difference between this. Okay. And obviously all these figures kind of feed into each other. But again, as a general point, when you're looking at papers and when you're looking at headache specific quality of life scales, MIDAS, hit six, you want to be seeing kind of, ideally you want to be seeing double digit improvements. That would be great. But MIDAS 4.5 plus, hit six 4 to 5 plus, in those sort of areas, then you're starting to at least get into something that is actually clinically meaningful in terms of actual patient, headache related quality of life.
Okay, thank you.
Does anybody on the call, anybody that's listening, anybody have any comments to make about the paper or anything they wanted to ask or add to what we've been talking about?
Someone raises hand.
Yeah, Deesh has got a hand up, but that may just be because that may still be up from when I asked people to put their hands up if they, so would think about asking about activity, physical activity.
So hi.
Anybody?
So
Hi.
hi. In that slide, it describes active individual were more likely to have post-secondary education and higher socioeconomic status. So it's taken like that. So my question is, so the better outcome, is it truly from physical activity or does it due to their better lifestyle, less stress, better access to treatment, something like that? Because
Yeah. Okay. No, I think, well, that's a very good question, isn't it? And how would you, if you were doing this study, how would you unpick those contributions? How would you, what would you do, statistically to try and understand that?
But I think they do the multivariate analysis after all.
Yeah. Yeah. So they did that, I think, didn't they, Dr. Zeyar?
Yes.
They did
They
a
multivariable regression. Sorry.
yeah.
Does it include that factor? Their socioeconomic status, education status in their multivariate analysis.
Just go back to the previous slide where you mentioned what they're actually go back one. So they did a multivariable linear regression adjusted for age, sex, marital status, children, ethnicity, and socioeconomic status.
Yeah.
So yes, I mean, the answer, the simple answer to your question is yes, they did do that. Although, these things, you're absolutely right. Is that the ability to exercise, the ability to have time to exercise regularly, may well be something that is not universal across all levels of socioeconomic status in particular.
Thank you.
Any other questions? Okay, so just go back to just go to your last slide, please, Dr. Zeyar. The questions for discussion. Yeah. Okay. So I mean, how can we better integrate lifestyle counselling into a clinic visit? I mean, I think it's an interesting thing, isn't it? I think probably the first thing to do is we probably should be asking more specifically about, lifestyle. I mean, people often tell you, people, you ask the question, are you fit and well? And people will often interpret that as a question about do they exercise regularly? They'll often tell you that they go to the gym, 5 days a week or whatever. But yeah, we should probably be asking, more specifically about that. But then again, difficult to what this paper doesn't tell us, and as the authors say, what we need maybe a little bit more clarity about is actually what level of exertion is going to be helpful. And all the debates about just the general should we be walking 8,000 steps a day, should we be walking 10,000 steps a day, should we be doing half an hour of physical exertion 5 days a week or 2 hours there is very little consensus on exercise as a general intervention for general health maintenance. So maybe an area that is open for lots of interesting kind of future work. And would we feel comfortable using exercise engagement as a clinical indicator for treatment de-escalation? So that's an interesting question, isn't it? And that feeds into the broader question of when do we we kind of concentrate on escalating treatment. We kind of concentrate on say, right, people are coming, we need to find things that are going to make them better. And it's a big question with regard to particularly to the newer drugs, to the CGRP drugs, which are, very expensive either to an individual person or to a kind of a healthcare system. So, we don't want to be wasting money either for the individual or for society generally. But we do have a lot less data to go on when we're talking about de-escalating treatment. So again, Dr. Zeyar, what are your thoughts? What sort of things would you traditionally kind of think about if you were kind of having that conversation about, well, how long do you need to take treatment for?
I think if the patient is stable or with the minimal effective dose, we might possibly think about de-escalation.
Yeah, I mean, do you have a kind of for a kind of days per month figure in your head when you do that, or when you think about that, or not?
I'm not very sure about it. Maybe maybe, one headache day per month. Is it
Okay.
enough?
Well, that's yeah. I mean, that's it's an ambitious target, isn't it? Um, for a lot of people. Um, I guess it depends, doesn't it? I think probably most of us would not have a set figure in our heads, would we? I think we would go for, the individual person. And again, it depends, it depends very much on, you know, some people will have, 4 to 6 headache days a month, but they can take, an acute painkiller and it will manage the headache and they can get on with their day and that's fine. And there will be some people who will get 1 or 2 days a month, but they do not have effective acute treatment and it will wipe them out for those 2 days. And it's not fine. So it is, I think probably most of us have a kind of general sense in our head that, okay, well, we want to improve matters for people, but if they're stable on preventive treatment for a period of time, then, actually, why not see if they can manage without it? Migraine, in particular, has a natural history. It rises and falls. People go through spells where it's very active and other spells where it calms down. So you don't want to leave people on tablets or injections that they don't need. But it is a difficult call. I think this is actually quite an interesting I think this is quite an interesting thing because it is a marker of function that may, again, if you kind of believe the results of this paper, why not? There is a reasonably solid threshold, isn't there, that they've identified, where the ability of people to engage in clinical in physical activity goes up quite sharply. So it might actually be a potentially helpful marker for improvement to a level where people may not need ongoing preventive treatment. But again, probably something that would be worth or would be important to kind of look at in more detail. I think we've got so few papers in the literature that look at what happens when you discontinue treatment. I mean, I can
Right.
think of probably 3 or 4 in total. Um, um, there was a paper about discontinuing topiramate, which was published about 10 or 15 years ago. There's 2 or 3 papers on discontinuation of CGRP drugs. But actually, it's an area that we have very little good data on.
Okay.
Anyone else have any comments to make? Okay. Well, look, yeah, as always, I'm incredibly grateful to those who spend the time putting together these presentations. Dr. Zeyar, that was a really good, it was a really good summary of what I think is actually quite an interesting paper and something that kind of makes us all think a little bit differently, which is kind of, which is good. So congratulations, well done. Really grateful to you for your time and effort in putting that together. I hope that people have found it interesting. I hope people have enjoyed it and enjoyed the discussion. As always, I will encourage those of you who have not yet presented in one of these journal clubs to do so. I think you will admit it's a relatively benign setting. The next one I think will be on Monday, the 3rd of August. Volunteers very welcome. And I think all of you, that obviously those of you who are working towards the fellowship, we kind of expect that you'll present at least once whilst you're in that process. So again, and again, I say the same thing as before. If you have papers that you want to present to the Journal Club, that's great. If you just want to present but you don't have a paper, then we can find some options for you. So again, thank you very much indeed, Dr. Zeyar, and all the best to all of you. And I hope that you have a good rest of your day wherever you are.
Thank you, Dr. Mark.
Hello, I'm sorry. Can I ask a question?
Sure, yeah.
Yeah, sorry for interrupting you, sir. I had a question regarding if a patient is complaining about mixed type of headache, he's a migrainer, and he's also complaining of post exercise headache. So in that overlapping type of headaches, how far is physical activity helping him?
Well, I think that, I mean, that's a good question, isn't it? And I guess the question is, when you say post-exertional headache, do you mean, are you talking about a kind of primary exertional headache, which is different and separate from the patient's migraine, or are you talking about migraines that are being triggered, in a delayed fashion by exertion?
Primary exertional headache, sir.
Okay. Well, so look, I mean, obviously, that's a tricky one, isn't it? Because if you say, okay, well, migraine can be improved by exercise, but then if you're getting an exertional headache that's triggering, that's triggering a different type of headache, then from that point of view, you're going to need to find some way of treating, ideally both of those in a preventive way. So exertional headaches are. Yeah, I mean, there are, traditionally it is said that beta blockers, can be helpful for that type of primary headache disorder, although again, the evidence base for that is pretty sparse. So I think pragmatically, you would have to kind of find some way of stopping exertion, triggering the headache so that, patients would then be able to exert themselves. And exertional headaches, whether they're primary or whether they're kind of after their exertions actually the migraine trigger, actually very debilitating and very difficult for people to live with. So yeah, I think, as I say, you'd have to try and find a way of managing those problems, and that might be one of those situations. It's a little bit like the kind of the sort of trapped cohort in this paper where you can't sort of go in initially and say, well, exercise is going to be helpful here, because actually they can't exercise. Obviously, in your scenario, it's a slightly different reason that they can't exercise from people that are just very badly troubled by very active migraine.
Okay, sir. Thank you.
Okay. All right. Thank you very much indeed, everybody. And we will see you back at the beginning of August.
Thank you, sir.
Thank you.
Thank you for the wonderful session, and thank everyone for active participation. Thank you.
Thank you.
Bye-bye.